So today's topic will be on MDT. So as you know that it has played a crucial role for many different specialties dealing with cancer, especially for lung cancer. In fact, there are lots of publications around the world that shows the impact on MDT on patients' survival, and in fact on patients' experience on their cancer journey. So it is something that you should aim towards, or if you don't have that in your practice already, you should aim towards setting out a MDT practice in your local setting, especially with Zoom these days or online platform these days. So much easier to meet up, and previously we were doing it physically, so everyone has to set aside specific amount of time and travel to one location, but now it's so much easier to just meet virtually online. The MDT today will be conducted by the Philippines Lung Center. Is probably the largest lung cancer center in the Philippines. So they deal with a lot of cancer work. And correct me if I'm wrong, Ed, you guys have this MDT meeting once a week, right? And it's best to have a MDT meeting on a regular basis, probably at least once a week, or if not, at most fortnightly. You don't want to leave cancer patients waiting too long for them to move on in their cancer journey, either through diagnosis or treatment, or indeed even just palliation. So you want to move them on as quickly as possible. In fact, the waiting time for a patient that presents in the UK with symptoms of suspected cancer is to be seen by a specialist within 31 days and to receive definitive treatment within 62 days. So that means if a patient presents with a cough, he should be able to see a specialist and have all the tests sorted out within a month to come up with a diagnosis and staging. And then for the definitive treatment, if indeed you progress on to treatment, either oncological treatment or surgical treatment or otherwise palliation within the next 31 days. So within 2 months, the patient should receive what he should be treated with. I think for many Southeast Asia countries, that might not be possible, but we should aim towards that. And in fact, we should lower that. We should, in fact, the patients that I see in the outpatient clinic, I often either put them on the surgical waiting list the following week or 2 weeks at the most. So the main issue is just the patients presenting late to the primary physician or to the, in our case, to the respiratory physicians. So once you receive and you work them out quickly, you're giving them a better chance for survival. Ed, are you on or still missing? But I see some of your colleagues on already. Would the colleagues from Philippine Lung Center unmute yourself, and maybe you could give a brief introduction, because they didn't send me your introduction or anything like that. So maybe you unmute yourself and give a quick introduction about your role in the MDT. Is that possible? Thanks. Let me see. Is it, I see two in, Tria and Chinky, is that right?
Yes. Hi, good evening. I am Dr. Peñano, Chinky Peñano. I am a radiation oncologist with the Lung Center of the Philippines, and I've been there since we started operations in 2002.
Have you all started the MDT for quite some time already?
Well, we've had a few MDTs, but of course because of the pandemic, we were not able to continue, but we were starting already because we had regular tumor board meetings. And what we're really working on now is our treatment protocol and our database that will be used nationally.
Well, very good. Maybe we can have a little bit more discussion on that later on. So Ed is on. Hi, Ed.
Hi, quite sorry for that uh, problem with logging in, so I gave the other panelists. So since this is a multidisciplinary team discussion, so yeah, I gave the login details as a panelist for the rest of the multidisciplinary team. So I hope they're all in. Again, let me first, I've actually invited the medical director, the executive director of the Lung Center of the Philippines. You sent the link to his email. So we'll probably ask him to talk later about, some things about the Lung Center of the Philippines. Let me first go and introduce the multidisciplinary team that we have. So I'm introduced the Dr. Ladera and Dr. Gonong already, and Dr. Lantin. We have Dr. Treya May Sayo. She is a pathologist, head of the anatomic pathology at the Lung Center of the Philippines, and Dr. Joseph Ubusan, a radiologist and the head of the Department of Radiology at the Lung Center of the Philippines. So let me just again, good evening to my friends and colleagues in the Philippines, in Southeast Asia, and beyond. Tonight will be a different type of seats meeting online conference, as we have assembled a multidisciplinary team of experts in their respective fields. And before we go on to discuss um, the two interesting cases will be presented, let me and Dr. Ladera discuss two short lectures to give emphasis on the importance of MDT approach to lung cancer and models of MDT approach. So let me start by showing two contrasting pictures. First, by vintage 1896 Ford quadricycle. It is the first gasoline-powered two-cylinder engine built by Henry Ford. And the second one, a modern one, a 2021 Ford Mustang V8 engine. Although there is definitely beauty in simplicity, we cannot deny the fact that complexity has its benefits, and it's part of evolution. And evolution is a progressive process towards successively higher levels of complexity. So in terms of evolution, um, being complex or complicated is good, but having a complicated status on Facebook implies a different thing. So how do we manage when things are complicated? In terms of managerial principles, we utilize work specialization or the division of labor, and a team approach or collaboration are used by managers to take on a complex task. They break down a complex task into simpler, more precise tasks. And over time, that person becomes a specialist, as he becomes more proficient and efficient. And with collaboration and communication, each member can be efficient in the completion of a task or a service. So applying this to lung cancer management, we are all already specialists. We are thoracic surgeons, we are oncologists, we are pulmonologists, and so forth. And we just need to collaborate as a team to work to make our work more efficient. So historically, a simple approach was applied for the treatment of lung cancer. So before, if you have an early stage, you do surgery. If you have a late stage, then you do chemotherapy with or without radiation treatment. And the increasing complexity of lung cancer can be brought about by recent advancements in lung cancer management, particularly the use of early lung cancer screening. We're getting more of the AAH, the AIS, the MIS for invasive adenocarcinoma, the new diagnostic techniques, particularly the use of PET-CT, endobronchial ultrasound. Some centers are using now navigational bronchoscopies, complex cancer staging. So our TNM stage is a bit complex. The ninth edition is due to come out in 2024, and they expect putting prognostic factors such as mutations of genetic codes might be included in the ninth edition. And the multimodality treatment algorithms are even becoming more complex to tailor fit the treatment. And biomarker-driven therapeutic strategies such as EGFR, ALKs, PD-L1s, ROS1, among others, and novel techniques such as treatment like TKIs, endoscopic ablation techniques, advanced radiation, and minimal invasive surgery. So MDT approach to lung cancer involves different specialties that collaborate to form a patient-centered, timely, and evidence-based diagnostic and treatment recommendation to improve patient outcomes. So it is becoming a standard of high-quality care for cancer, and it is designed to ensure rapid diagnosis, staging, and decision-making, and the provision of radical treatment whenever possible. So let me emphasize the word rapid. How rapid is rapid? Well, with regards to time frame, the UK NHS requires a case to be discussed, as mentioned earlier by Dr. Soon, by an MDT within 3 weeks of the initial triage, and any additional investigations should be performed within the following week. For the Dutch recommendation, it says that 80% of patients should have a complete diagnosis within 3 weeks of presentation. And of these, 80% should start treatment within the next 2 weeks of diagnosis. So when is multidisciplinary team management beneficial? The NCCN and the ESMO recommends MDT if when the biopsy is impossible during diagnostic evaluation. Number two, for disease settings with multiple treatment options, for example, borderline resectable disease, synchronous oligometastatic disease, which require a case-by-case evaluation. Again, also for patients unsuitable for optimal treatment, for example, patients who are for surgery but who cannot tolerate it because of medical conditions. That necessitates a per patient level discussion about suitable treatment options to ensure optimal outcomes. Another is where in clinical scenario when diagnostic and therapeutic decision is unclear, or where in scientific data and clinical practice guidelines may be lacking, such as rare disease, or those with gray areas wherein the data is conflicting. It is useful in all stages of lung cancer, but it may particularly benefit patients with small nodules detected on low-dose CT screening for maximizing radical treatment for early stage lung cancer, and for stage 3, particularly, and also stage 4 non-small cell lung cancer. So in this particular study, data actually on the use of MDT approach in improving outcomes are sparse, particularly for lung cancer. And this is one of the few studies that does address that issue. This is a large-scale retrospective study comparing survival outcomes among those treated by MDT versus traditional care. And this involved more than 4,000 patients with lung cancer identified by institutional cancer registry spanning for about 15 years. The result of this study showed that MDT model demonstrated a significant benefit both at 1, 3, and 5-year survival outcomes compared to the standard treatment model. So the benefits to achieve with an MDT approach includes, for patient benefits, improved survival, increased satisfaction, greater likelihood of receiving guideline recommended treatment, increased access to information, and a more streamlined access to care. Potential benefits for clinicians include increased evidence-based care, consideration of all treatment options, streamlined referrals, enhanced educational opportunities, collegial interaction, and improved access to clinical trials. Okay, so do we have Dr. Guia already logged in?
Good evening, everybody. So
Good evening.
let me just start off with a topic on multidisciplinary care models for patients with lung cancer. Next slide, please. So we all know for a fact that lung cancer care, it has a complicated nature, and being so, it needed a unique coordinated unique coordination among all disciplines will work with the case, and this must be done in a timely manner, because time is such a perishable resource for these individuals. And also, to deliver a high quality of patient care, we need to put all this multidisciplinary team together, coordinating, and hopefully the end result of their efforts will be to improve the healthcare services and patient outcomes. The focus of MDT actually is to simplify and facilitate a dialogue and subsequent ongoing collaboration or cooperation between the healthcare provider as well as the other expertise and ancillary services that need to work together in a case, and they should reach a consensus that is evidence-based management that is tailor-fit for the patient's need. Next slide, please. So there are several lung cancer care models, and these are the serial referral system, the multidisciplinary team meeting or the tumor board focused model, and the MDT clinic-based model. And depending on your infrastructure, resources, the local SOPs or quality standards, this may vary from country to country or from different institution. So actually the multidisciplinary team involvement may be continuous as a patient progresses through their treatment pathway, or it is fragmented and on a quote-unquote on-demand basis. Next slide, please. So in the next few slides, I will be discussing each one of these lung cancer care system. The first one being that of the serial referral system. So with the serial referral system, the patient is referred to individual specialists, and each one offers their expertise and opinions as the patient progresses either in their diagnostic or treatment journey. And this is what we call as the refer as you go system, and this is shaped by demand. That being the nature of the serial referral system, it has several limitations. Number one, it may prolong the pathway of the patient. Different specialists have different schedules, and for example, one specialist need to rely on a different expert's opinion, then there is some kind of a waiting time before eventually a decision or a consensus or a decision is made. And sometimes being on isolation mode, this may lead to inappropriate choice of treatment options because the expert might be offering an option that that is easily accessible to them, or probably they are more familiar with, not hearing out the opinions of the others in the team, and therefore come up with a treatment or diagnostic plan that may not be tailor-fit to a patient's need. Next slide, please. So from there, from serial referral, we go to the next one, the MDT meeting or the focus model. In the MDT meeting, then the experts as well as their partner ancillary service meets, and then a specific case of a patient is presented and discussed, either to discuss the treatment or diagnostic dilemma of the case. So with this type of lung cancer care, we are ensured that there is a collaboration because they cooperate, they have integrated their opinions compared to the serial referral system, where the expert works by himself and formulate a plan according to how they see a certain case. And because the experts are all present and they discuss the continuum of care from diagnosis, treatment, and surveillance, and end-of-life issues, then the patient is ensured a continuum of care. The limitation here is that there should be a comprehensiveness in the presentation of the case, because the quality of the presentation heavily affects the quality of the diagnostic or the therapeutic recommendation that is made by the team. So it is very important that the cases be presented by a healthcare professional that's very familiar with the patient's case. Next, please. So this one is the MDT Clinic-based Model. So this is a dedicated centralized cancer clinic space. All the specialists that need to be involved in the care of a patient with lung cancer and all ancillary services like nutritionists, pain management, social service are all housed in a centralized cancer space. And so all these services being in one place, this offers a great opportunity for a patient to engage to each of these specialists or service, depending on the point where they are on their pathway. And so the patient have an easy access to all these specialists and services. However, the downside of this MDT clinic-based model, it is very heavy on resources. Next slide, please. So one of the essential aspects for lung cancer care is that they must be patient-focused. And this greatly relies on communication, collaboration, and the streamlining of the treatment and diagnostic pathway of each patient. So next slide, please. So like any of the service, there's a challenge of setting up a functional multidisciplinary lung cancer service. There must be a commitment that each member give ample time to attend to their meetings, and they should be given some kind of protected time when a meeting has been set up, and also some time to be able for this team member to work on the administrative side of the MDT. Dedication, we can underemphasize that each member is dedicated to their role, and then it should have been a good number of resources, because there should be a continued exchange of information between each member and the member to the care provider or the patient themselves. Also, an efficient leader or an efficient team leader is very needed in a functional multidisciplinary lung cancer care service, and this leader must be able to be non-biased, that all opinions should be heard and considered, and there must be documentation and all the other stuff. So other things that are also important is for the team to develop their own processes and come up with a communication, again, communication between each member to the team leader and to the patient and their care providers as well. So just to summarize, the next slide, please. So as I mentioned, lung cancer care has a complicated nature, and this mandates a unique level of care coordination. And this should be done in a timely manner. There is an interprofessional multidisciplinary teamwork that should be considered, because this is an essential component to deliver a high quality patient care for those with lung cancer. Multidisciplinary care has been the cornerstone for the diagnosis and treatment pathways of lung cancer patients. There are several lung cancer care models which were briefly discussed. These are the serial referral system, the MDT meeting focused model, the MDT clinic-based model. Each one has its own benefit and shortcomings. The challenges of setting up a functional multidisciplinary lung cancer service has also been discussed, and should be monitored and continued. There should be a continuous evaluation of the efficacy of this multidisciplinary lung cancer service for it to serve their lung cancer patients better. So with that, I would end my very short lecture so we can proceed with the two cases that will be discussed. Back to you, Ed.
Thank you, Dr. Guia. Proceed with the case. So the first case is a 66-year-old male with COPD presenting with cough. He had a PET CT scan with December 2020 with 4.7 by 5.2 by 4.7 cm spiculated pulmonary mass in the left upper lobe with an SUV of 12.5. He also had a 1.2 centimeter subcarinal lymph node with an SUV of 4.9 and sub-centimeter lymph nodes at the left hilum and para-aortic area. A CT scan guided biopsy was done, which showed adenocarcinoma of the lung. So in this particular case, what is the next best step in the management? Either A, we do a neoadjuvant chemotherapy and radiotherapy. B, do we do endobronchial ultrasound, transbronchial needle aspiration biopsy? C, mediastinoscopy, or D, VATS, left lower lobectomy with mediastinal lymph node dissection. So can we first get our comments from our oncologist, Dr. Ging, and also our radiation oncologist, Dr. Lantin?
Okay, so regarding this case, this looks like a clinical N2 disease, and then well, the NCCN guideline would recommend a neoadjuvant treatment. And so neoadjuvant treatment may come in the form of alone, chemotherapy alone before surgery versus chemo-RT. Well, there are several RCTs or randomized controlled trial that compared resectable non-small cell lung cancer with neoadjuvant chemo versus surgery alone. And they found that there was approximately about 16% risk reduction for death or for recurrence of the disease. On the other hand, the National Institute for Healthcare Excellence, or the NICE guideline, had recommended concurrent chemo-RT for patients with N2 disease who are deemed to be probably resectable. And there was really no statistical significance towards efficacy, but there is a trend towards efficacy or survival benefit for those who were given concurrent chemo-RT prior to surgery. And also, they did a cost-effective study, and they found that concurrent chemo-RT is the most cost-effective treatment. And the second one will be the definitive chemo-RT, and then the least effective will be those who had surgery followed by chemotherapy. And so with the NICE guidelines, they recommend that for resectable N2 disease, if the patient is fit, then the suggestion or recommendation will be for them to undergo concurrent chemo-RT neoadjuvant.
So can I ask a question? So in the Philippines Lung Center, for patients with clinical N2 disease, when would you guys stage the mediastinum through a biopsy of some sort, whether through EBUS or mediastinoscopy, to try to clinch that it is true either N2 or N3 disease? Do you go by the do you just rely on the PET and forego mediastinal sampling, or would you go case by case? Depends on the avidity, depends on how many lymph nodes there are, how many stations are involved, the bulkiness of the lymph nodes. And so what in the Philippines Lung Center, what would guide your treatment rationale in patients with N2 disease, with suspected N2 disease with on PET scan?
Ed, would you
Yeah.
want or Bong to Dr. Gonong to answer for that question?
Yeah, Dr. Gonong, our interventional pulmonologist, maybe can answer that question.
Yeah, okay. Good evening. I'm Dr. Gonon. We had the endobronchial ultrasound in 2017 and doing it October. So ideally, the preferred modality for sampling the mediastinal lymph nodes is through the EBUS TPNA, or if you use the same scope, to use FNA. Because of its minimally invasive nature and the high diagnostic yield, since we already have the rapid on-site test when we're doing the procedure. And like in this case, you have 2 stations for the N2, station 7 subcarinal, and which is accessible by EBUS, but not the para-aortic station or station number 6. And you also have a hilar lymph node, station 10, which can also be sampled. So I think it's important to accurate the stage using minimally invasive procedures like the EBUS in staging the mediastinum to avoid unnecessary invasive procedures, including thoracotomy and surgical resection. So, of course, I would recommend, if I'm gonna choose my answer, it would be letter. It would be okay. I'll choose B.
Would you do it for every lung cancer case, or would you do it for cases that are lighting out on PET, or would you do it depending on the size of the lymph nodes, or would you do it depending on the size of the primary lung cancer?
Well, it will really depend. If you have an 82-year-old female with para-aortic encasement and obviously with poor functional status, I don't think staging the mediastinum will be necessary, because obviously the patient may not be resectable. But for lesions, especially if you think that you need to stage the mediastinum, because you might think that you have a stage by you're able to stage a lung lesion that is still resectable, then obviously it would be a very good interventional procedure, minimally invasive.
For example,
well, it will really depend also.
Okay, if there are no lymph nodes, let's say if just for this case, patient looks pretty fit for surgery, and there is no lymph nodes lighting out on PET scan, but a tumor is 5.2 cm in maximum diameter, would you stage the mediastinum?
Well, if it's in endobronchial ultrasound, actually, we're kind of obligated to do sampling if the size is more than 0.5 cm. But in this case, we have a 1.2 cm subcarinal lesion, as shown in this case. So I would still go after the size of the lymph node is also very important when we want to use this procedure.
So your screen.
So our cutoff in our center is 0.5.
Oh, okay. So your screen with the CT scan first and the size on the CT scan first, is it?
All right. And we have seen cases, lymph nodes which were not reported on imaging because maybe the imaging were done ahead of time. When we do the endobronchial ultrasound, lesions that were not tagged earlier can be seen by the endobronchial ultrasound, and we have the chance to sample these stations also during the procedure. when we're doing surveillance of the mediastinum and checking for the differentiations.
Okay, yeah, we do follow the NCCN guidelines regards invasive mediastinal staging, and we do use the EBUS quite a lot in doing the mediastinal staging. We do rely on imaging to guide us with regards to the use of invasive mediastinal staging. In this case, particularly the use of PET-CT, although not all patients can actually afford a PET-CT scan, but in most cases we do request for it. I think here in this particular choice, the choice of mediastinoscopy, it's not. We do use EBUS as a front line in doing our mediastinal staging, and we do reserve mediastinoscopy. And if we need to do a restaging after a neoadjuvant treatment, I wouldn't go for an outright left lower lobectomy and mediastinal lymph node dissection in this case. Is if you haven't done a complete invasive mediastinal staging. So like in the NCCN guidelines, we don't actually do outright surgery for a stage clinical stage 3A lung cancer.
There are a lot of participants that is on at the present moment. So if you have any questions, please type it in the Q&A section, and I will voice out your questions. Let me see. I think there might be one. So from Prof. Argus, so what is the opinion of the panel radiation oncologist on role of radiotherapy in stage 3A lung cancer?
Hi, good evening. So for locally advanced lung cancer, like what Dr. Ladera has mentioned, we have an option to do radiation concurrent with chemotherapy. But this is very important for us to talk to the other doctors involved in the care of the patient, because our radiation dose will differ if it's if you were doing radiation prior to surgery or if it's definitive radiation. So I think before actually subjecting the patient to radiation therapy, we really need to discuss with the other doctors if the patient will push through with the surgery.
So
when you do radiation planning, do you include both the tumor and the lymph node that's involved? Like in this case, a subcarinal lymph node and also the tumor in the left lower lobe.
Yes, so we look at the size of the lymph node. So of course, we try to, because of the location also of the lymph nodes, it's close to the heart. So adding radiation there can mean more radiation dose to the heart. So we really try to see if radiation is warranted to that area. So usually when we see that if it's more than 1 centimeter and it has like in this case, so we include that in our treatment field as well.
You encompass it in one field or 2 fields, or?
We try to do one field only for this one, but different radiation beams, but in just one treatment.
Okay, let's say Ed is very brave in taking a patient on after your chemo radiation. How many grays will you give if he decides that he will take the patient on after you give some definitive chemo radiotherapy?
So if we're doing neoadjuvant radiation with chemo, there's usually give a range between 45 to 54 grays.
And if he decides not to, you'll go up to what, 65 grays or what?
Yes, 60 at the minimum.
60 at the minimum. Okay. And how many patients that you give concurrent chemoradiotherapy drop out from their treatment course? Because do many patients drop out if you give concurrent chemoradiotherapy? Or
so far in our experience, so far personally, I've only seen very few, maybe just 10%, maybe. I'm not sure with Dr. Ladera, but with the patients I have seen, not too many. Most are able to complete the course of chemo.
From my end, likewise, a good number of patients were able to tolerate concurrent chemo RT rather than dropping out, but sometimes they do have some treatment interruptions because of some generalized body weakness, and sometimes because of decreasing WBC count and anemia, but not really dropping out or discontinuation of the treatment.
So most of your patients will be able to complete concurrent chemo-RT.
Yes.
Okay, very good. From a question from Dr. Castolo, the case, or I think it's just a comment. He says the case has all the characteristics to do pre-op invasive mediastinal staging prior to treatment. Treatment option, tumor size, positive PET scan, histological, that is adeno RCA. So invasive, probably he meant mediastinoscopy. Is that something that you will do in the lung center prior to EBUS, or you will go for EBUS first? If it's negative, then you will proceed on for mediastinoscopy, or do you take the negative result from EBUS as negative?
Well, if the PET CT and the EBUS turns out negative, there's a high likelihood that it is actually negative. So then we don't proceed to more invasive staging anymore, unless these are large lymph nodes. But it's quite unusual that large clinically enlarged lymph nodes will turn out negative with endobronchial ultrasound. So we do have very high yields with the EBUS, PPNA.
Because you have rapid on-site, isn't it? That's what.
Yeah, rapid on-site. Yeah. Yes.
That's very useful actually. Not all the centers will be able to have rapid on-site. So I think that's a big advantage that your center have with their EBUS service, rapid on-site.
Mm-hmm.
So the next question is from Dr. Sira. He says that if the EBUS is negative, do you proceed on to mediastinoscopy, which you have answered that, or do anyone straight away go for lobectomy? Anyone wants to take that? Anyone thinks that if the EBUS is negative, do you go for lobectomy and straight away for lobectomy in such a case, or you would go for your mediastinoscopy first?
I would probably, that would be the indication for doing a mediastinoscopy, considering that the findings on the PET CT and the EBUS are not congruent. So if you have this discrepancy in that, and you feel that that 1.2 centimeter subcarinal lymph node with an SUV of 4.9 is positive, then you do a mediastinoscopy for that.
Okay, so from Prof. Agustin, it says that what is the treatment for stage 3B lung cancer in the Philippines lung center? So maybe it's the oncologist wants to.
Dr. Ging.
That would be hello. Yeah, for 3B concurrent chemo RT non-progressing, then they will proceed with durvalumab if cost is not an issue for these patients.
So after your concurrent chemo radiotherapy?
Non-progressing patients are recommended to proceed with durvalumab.
Okay. Is it on your, do they have to buy it privately, the IOs, or
they need to buy it privately, and also only after applying to the local FDA, because that drug is not yet currently available in the market. So most of our patients who would go for durvalumab need to apply for exportation of that, importation of that drug.
Any other comments from the panelists?
We can proceed to the case then. No other questions?
There are two more. Can I ask? Yeah, since they are getting hot. So what is the time frame for surgery after induction chemo radiotherapy? Ed, how
Yeah,
long do you wait?
we
Come
normally wait
soon.
for about 4 to 6 weeks after. Repeat the look at the blood picture. If the patient has recovered already, then we can then proceed uh, to surgery after.
You restage the mediastinum as well, and you rescan, and obviously you restage everything, or what? What do you do?
Yes, yes. Well, it's going to be part of the what happens to this particular patient, because in this particular patient, although because this was done outside the lung center of the Philippines, so um, there was no invasive mediastinal staging that was done, but the patient was assumed to have a stage 3A, and a neoadjuvant chemo and RT concurrent treatment was done. And after that concurrent chemo RT, the repeat scan showed a decrease in size of the mass, now measuring 2.8 by 4.5 by 5. And the avidity has decreased from SUV of 12.5 to 10.4. Likewise, the lymph nodes, the station 7 lymph node decreased in size. Now it's sub-centimeter. The SUV likewise went down to 2.3 from 4.9. The previous left hilar and para-aortic nodes resolved metabolically. So in this particular patient, normally, if your question, do we do restaging? Ideally, we should do restaging. That's why we reserve particularly mediastinoscopy. We can actually do a repeat EBUS TBNA, but we do reserve mediastinoscopy for restaging in these cases.
So if the lymph node is still positive, how would it influence you?
Then probably it proceed for a definitive chemo RT. Then
If
if
it's
the patient
just positive in a station 7 area,
yes,
you would not take the patient for surgery for your practice in Philippines.
normally proceed with, if it's not responsive to neoadjuvant, then we'd proceed to definitive chemo RT then.
No, I mean it's responsive. It's coming down in size. It's less hot on PET. The lymph node size has decreased, but on repeat EBUS, it is still positive in station 7. What would you do then? Would you say go for definitive chemoradiotherapy, or would you take the patient on and take out the lymph nodes in station 7?
Yeah, if it has probably decreased in size, it's considered a partial response, then you can opt to remove it, especially if the size is already sub-centimeter.
Yeah. So these are different treatment options available, isn't it?
Mhm.
Yeah, especially in fit young men, might give him the benefit of doubt. Okay, there are a few more questions. Or do you have more presentations? More on this case?
Yes,
Or
actually a few more.
okay.
We can proceed. So
Yeah.
again, this is particularly the question that was asked after a partial response. Then what is the next option? I think we have discussed this already. Just um, showing the surgery that was done here. So after the neoadjuvant treatment, you can see there that the mass in the left lower lobe. There was a lot of dense adhesions because of the concurrent chemo RT in this patient. So after doing adhesion lysis, where adhesions along the chest wall, along the diaphragm. After doing that, we released the inferior pulmonary ligament. And uh, dissected station 9 lymph node. There was a station 9 lymph node, more or less about 0.8 centimeter in size, which was taken out.
Positive?
This is station 9 lymph node.
Positive?
Yeah, it will be discussed later by our pathologist.
Okay.
So I'm going around the posterior part of the hilum and isolating the inferior pulmonary vein. So after stapling that inferior pulmonary vein, we go towards the fissure. So you can see there the pulmonary artery, interlobar pulmonary artery. We're now dissecting along the anterior part of the fissure. Then further completing the posterior part of that fissure, major
This is
fissure.
after 45 grays and 4 cycles of neoadjuvant, or what?
Yes. Neoadjuvant, I believe it was only 2 cycles.
2 cycles.
Given. Yes,
Okay.
2 cycles given.
And
So
45.
we then staple the A6, and followed by the A8 to 10. And then the lower lobe bronchus. Kind of using different mix of staplers, if you can notice. Here I'm harvesting the station 7 lymph node, which is fairly huge compared to the other nodes. And likewise, the station 6 lymph node. So these are all submitted. You can see there further along the apex, there's a bulla. So this is a COPD patient. So we likewise resected that, did a bulectomy in that bulla. Okay, this is the post-operative X-ray. So can we call on our pathologist, Dr. Treya Sayo?
Yes, good evening. Good evening, everyone. I'm Dr. Sayo, lung pathologist. And here are histopathologic diagnosis for this case is a residual adenocarcinoma with a tumor bed size of 3.8 centimeters and invasive tumor size of 1.14 centimeters. The tumor bed is composed of 3 major components. We have viable tumor, necrosis, and stroma, which the stroma includes fibrosis and inflammation. So our diagnosis was based on the recently published multidisciplinary recommendation for pathologic assessment of lung cancer resection specimens after neoadjuvant therapy by IAS LC members. So for this case, we have 30% viable tumor, 10% necrosis, and 60% stroma, which in this picture, you can appreciate moderate inflammation, cholesterol cleft formation, and patchy fibrosis. Next slide. So the 30% viable primary tumor is predominantly composed of a high-grade micropapillary pattern. As you can see, tumor clusters floating here and there, with some cells along the alveolar walls are forming also a filigree formation. So in the picture, upper picture, on the right, you can see a tumor bed edge showing a substantial area of collagenization, and then higher magnification. The lower right picture shows extensive nodular fibrosis and inflammatory infiltration with some scattered atypical cells with enlarged hyperchromatic nuclei reminiscent of a tumor regression. Next slide, please. Out of 8 lymph nodes examined, including the 4 lymph nodes from the subcarinal area, showed no pathologic evidence of viable tumor metastasis, except for the 1 lymph node taken from the station 9, which showed treatment-related changes with 100% stromal treatment effect. So shown here is a part of a nodal tissue with some residual lymph lymphoid cells and anthracotic pigments. And at the periphery and adjacent to it are the extensive area of fibrosis and inflammation, which are both components of the stroma. So such findings for this particular lymph node may suggest a complete pathologic response to treatment. Okay, that's all. Back to you, Dr. Ed.
So the station 7 was negative.
Negative, with no evidence of tumor involvement.
So the station 9 was the one who turned out to be
Responsive to
responsive.
Yeah.
So I was surprised that you can actually detect whether a particular lymph node has been involved with tumor and had a treatment response to the concurrent chemo and radiation.
There's no evidence of pathologic response, so I think it's negative to begin with. So
was it, so the station 7, was it sampled before the operation?
it was
No.
Station
Before the operation, you mean?
Yeah,
In
operation.
staging. Unfortunately, in this patient, it was not done because the patient was just referred to the lung center for surgery, and the neoadjuvant treatment was done outside.
Okay. So, Dr. Sayo, can I ask, if the patient is from the Philippines Lung Center and he has adenocarcinoma, would you guys proceed on to reflex testing for all the different panels, or what would you do in the Philippines Lung Center for patients with adeno-CA?
For the immunohistochemistry, we usually do reflex testing, like to confirm if it's adenocarcinoma. We usually do 2 panels, like TTF1 for adenocarcinoma and P40 to rule out squamous cell carcinoma. And for biomarkers, we still have to set up the molecular testing. We have the EGFR and the ALK and ROS1 for immunohistochemistry, but the FISH confirmatory testing, it's not yet available in our center.
Okay.
It's not yet a standard of care to do reflex biomarker testing for early stage in the Philippines. But we know for a fact that there is a good evidence for adjuvant osimertinib for patients who had resection based on the ADORA trial. So this may be something that's in store for us in the Philippines in the future. But unfortunately, because osimertinib is quite prohibitive for most Filipino patients. So probably on selected individuals who might be open for adjuvant osimertinib, it may be a treatment pathway for them to test for EGFR on the early stage of the disease.
A question from Dr. Anis from Singapore. He says, what is the panel's opinion on neoadjuvant IO for stage 3 lung cancer? Any opinions on neoadjuvant IOs? Chemo IO or IO?
Well, there are ongoing clinical trials for the use of IO in the neoadjuvant setting, but not yet a standard of care in the Philippines. So we're waiting for results coming in, and after that will be approval in the local Philippine FDA for its use in the neoadjuvant. So seems to be a promising tool again for patients in the early stage of the disease. So we have biomarker TKIs and probably immunotherapy neoadjuvant in the neoadjuvant setting. we'll see.
Okay, and a question from Dr. Kazi. It says if a single station N2 disease, would you go for upfront surgery? That means don't go for any induction therapy and just go straight for surgery. What are your feelings on that, panelists? Upfront surgery, straight for single station N2 disease? Is that do you all practice that in Philippines Lung Center, or would you, for all patients with N2 disease, you will go for induction therapy?
Yeah, before it was a practice, but since we had the tools for invasive mediastinal staging, then we do invasive mediastinal staging for all, even for a single station. Even if it's positive, then we do we follow the protocol for stage 3A, which is neoadjuvant concurrent chemo RT.
Okay, so you wouldn't proceed straight to surgery first, then followed by adjuvant chemo?
Yeah, because well, based on past experiences, when we do have a single station, eventually you do surgery, you actually see multiple stations, and it's rare that you see a true single station in these cases. Once you actually get multiple stations, eventually when you do surgery and send it for histopathology. So it's not just a matter of removing the lymph node, but rather improving the survival of this patient. That's why we're going after a concurrent neoadjuvant chemo and RT.
And then I think the follow-up question by Dr. Christina, I think we have answered that. Then we will follow up by reassessment with PET CT, isn't it? After your neoadjuvant chemotherapy. I think that's what you said you do in the Philippines Lung Center. Yeah. Dr. Sira, I think also single station N2 disease question. I think we have asked that. Dr. June Paul Costello, role of neoadjuvant chemotherapy. We have answered that. Dr. Raja was mentioning any difference in taking the next step for this case if molecular testing shows targetable genetic mutation versus non-targetable genetic mutations. So if this patient turns out to be EGFR positive, is there a difference? Would you go for induction TKI rather than induction chemoradiotherapy for N2 disease? Would you?
Well, there are some evidence from the adult trial that there is an 11 months advantage for those who receive adjuvant osimertinib for patients with resected non-small cell lung cancer, especially for those with stage 2 and 3. I think it's the ones that got the most benefit.
Yeah, that is in the adjuvant setting. So how about in the neoadjuvant setting?
Oh, in the neoadjuvant setting.
Yeah.
Wow.
Would you downstage the patient with TKIs if it is EGFR positive?
Well, that's a possible pathway for EGFR positive patients, but well, we really need more data regarding its utility in the neoadjuvant setting based on well-designed clinical trials.
Yeah, that's very pertinent. But I must say in my practice, patients tolerate TKIs much better than they tolerate chemoradiotherapy. So sometimes we do give, I know it's outside of published evidence, we do give induction TKIs to really bring down the tumor load and then perform surgery and then go for adjuvant chemo after that, followed by maintenance TKI. So question from Prof. August. Do you buttress the bronchus after your chemoradiotherapy? Ed, do you buttress in this case?
No, we did not buttress in this case, but we do sometimes apply synthetic glue in the bronchus. In this particular case, no, we did not put anything. We don't use it routinely, buttressing. We do that for inflammatory cases, conditions, but not for this particular case.
So if this patient requires a pneumonectomy instead of a lobectomy, would you go ahead to do it, Ed? After induction chemoradiotherapy, if this patient has a more central tumor responding after the induction chemoradiotherapy, but it will require a pneumonectomy for clearance, would you go ahead and operate on this case?
Yeah, it really depends if the patient can actually tolerate it. If the patient has a good pulmonary function, and that's the only way we can actually achieve cure in this patient, then yeah, it's an option. Yeah.
And you will buttress in this case for pneumonectomy?
Yeah, we probably buttress with pneumonectomy. Yeah.
Okay.
In this particular case, if it's left side, it's quite deep actually. So a lot of tissues that you can actually use to buttress that, especially for left-sided pneumonectomy.
Okay. Okay. I think that's about all the questions. I think. Okay. And do you have any more to go on? I think that's a lot of questions from the participants. So you can see how much interest your case in the Philippines has generated among the Southeast Asia country.
We actually have one more case, but I don't think we have time to present it. A carcinoid tumor that had bronchoscopic cryotherapy followed by sleeve resection. But I don't know if we have. We're going over time already.
Oh yeah. Gosh, how time flies when you're having fun, isn't it? Yeah. So let me wrap this up. If there is no other comments from the panelists, anyone else wants to offer any more comments? Okay, hold on. Huh? There might be some more questions coming in from Dr. Li Yue from Singapore. I think, what is considered effective neoadjuvant on restaging scan? Any specific criteria? What is considered effective for you? A drop in 50% in avidity, a drop in 50% in size? What is effective neoadjuvant for you?
They've actually described this in literature as 30% reduction as a partial response. Yes, in the size, as a partial response. Some studies are studying the use of SUV, but there's no clear consensus on that, on the utilization of SUV for as a means of gauging response to treatment.
So in Philippines, how would you consider effective? Depends on the coffee that you had in the morning. Yeah, I feel like taking this on today. Yeah, so it's effective. It's difficult, isn't it? Sometimes. Yeah, I also don't have a definitive criteria. I'm just wondering whether any of the participants have a definitive criteria that they follow. What is considered effective?
I'm not quite sure about the PET-CT SUV uptake criteria for response, but if we're using the RECIST criteria, then 30% reduction for the original tumor will be what I can consider as response to treatment and proceed to the next best step.
Okay, so there you have it, Dr. Liu. Maybe a 30% reduction on the restaging scan, 30% reduction in diameter on the size on the restaging scan. Okay. I'll conclude. So thank you very much to the Philippines Lung Center. It's no mean feat to get everyone involved. Thank you very much for all this coordination. Really impressed with the way that your team is set up. As Ed has mentioned, lung cancer care is getting more and more complicated, and treatment is getting more personalized, isn't it, for each individual patient. So the way of dealing with all these patients is through MDT. And I hope that the participants, whatever centers that you are in, if you don't have an MDT, please do set it up. and get it going, because there's evidence to show that you will make an impact in patients' prognosis and even quality of life, even if they have required palliative care after your discussion. So it is important. We would love to hear your experience in setting up MDT across Southeast Asia. So do share it with us, and there's probably going to be a forum in Seeds for all this. So do send in your feedback. So thank you very much once again to the Philippines Lung Center. Very well done to you. Really, really impressed with how your team has all coalesce around the patient. This is patient-centric care, isn't it? The patient is in the center. Yeah, we are all in the periphery. We are all trying to deliver the optimal care for this single patient. It's not like, the patient belongs to the surgeon, the patient belongs to the oncologist or the radiation oncologist or the respiratory physician. It's like everyone working the best for this patient. So thank you for that. Thank you, everyone. Thank you to the participants. There's a huge turnout tonight. So see you all for the next meeting. Bye.
Thank you. Bye.